I chaired a symposium earlier in the week, and one of the components there was a year is a long time in CLL. And in the last year there have been many changes, but there are some important things that have not changed and been reaffirmed. So within the updated IWCLL guidelines that Michael Halleck has led the publication of, that has reaffirmed the importance of or the role of observation in patients with early stage asymptomatic and low tumour burden disease. So despite the efficacy of new agents and combinations that we'll talk about, in patients with early stage asymptomatic and low tumour burden disease, there remains no benefit and no justification for initiating treatment, very importantly. One of the changes is a greater emphasis on the value of attaining MRD negativity, both as a therapeutic endpoint for an individual patient, as well as a measure of the relative effectiveness in clinical trials. And one of the emerging themes is, despite the effectiveness of many novel agents such as the BTK inhibitors or the PI3 kinase inhibitors, as single agents they're not able to achieve that depth of response. Venetoclax, the first of the BH3 mimetics, as a single agent is able to do that, but where the field is beginning to move is exploring rationally designed combinations and using the attainment of MRD negativity rate as an indicator of the relative effectiveness of those regimens. BTK inhibitors with CD20 antibodies has been explored, and that, to my interpretation, doesn't provide a positive signal in that direction. Conversely, using venetoclax as the core of those combinations, either with a CD20 antibody, rituximab or obinutuzumab, both can safely be delivered, or with a BTK inhibitor. Paulo Guia has presented very impressive MRD negativity data with venetoclax and ibrutinib. The field is potentially moving towards the triplet using BH3 mimetic, a BTK inhibitor and an anti-CD20 antibody, with the goal of very compressed duration of treatment with hopefully very prolonged time off therapy for our patients. So that's where the field is beginning to move in a thematic sense. All of this is early data with preliminary clinical trials, and we will need longer follow-up and comparisons against standard chemoimmunotherapy and against continuous treatment, which is the current paradigm, with single novel agents to ultimately determine the way forward.